But it's great to have everybody here again. As you know, I'm Dr. Adam Hogan. Nice to see some familiar faces here in the audience that were here last month as we continue this series on. I want to thank you for taking your evenings to spend with us. And I know you all worked very hard. You've had a long day. It's already midweek and you're looking forward to getting home. So I really appreciate your time very much. I promise to make this worth it. We've got a great case to show you tonight that I think you'll learn a lot from. And without further ado, we will get started a little bit. Quickly aside, there's a few new faces. Going back in my history, I started out as a United States Marine, and I went back into college at University of Michigan. And yeah, believe it or not, don't snicker, Anne-Marie, in the back. That is me a long time ago, not my son currently, who's 19 and looks just like that. But yeah, I went to, thank you.
I appreciate you.
Thank you very much. Went to University of Michigan School of Dentistry, and then back in the Navy as a dentist, and then Portsmouth Naval Hospital where I did my general practice residency, and then onto a maxi course at the Medical College of Georgia. I want to kind of fly through this because we're getting a little bit of a late start, and I want to get to the later slides. But I did my credentials with the American Academy of Implant Dentistry. Those of you who were here last month saw my first implant, my first quad, and my first full arch reconstruction right here. That was my associate fellow exam in Chicago. I think credentials are extremely important to me. I have to thank my mentor, who you'll see here in a second. He was supposed to be with us tonight, but he has to be with a friend in Winchester. But he told me, he said, boy, get your credentials in the AAID. It'll be the greatest thing you ever do. And he was absolutely right, because it put me on this path to diplomate of the American Board of Oral Implantology. And this is just a slide that shows that track as a licensed dentist to a member to associate fellow and diplomate. And I now proudly serve on the admissions and credentialing committee in Chicago for the American Academy of Implant Dentistry as a board examiner. And that's definitely an honor for me. And there's the, I'm very proud to say, as a specialist in dental implants, certified in everything from diagnostics to the maintenance phase. That's very important to me. As I was coming out of the Navy, it was I wanted to go into surgical specialty, but I didn't want to be constricted with just being allowed to only do the surgery and not the reconstructive phase of dentistry as well. So that was one of the issues that prompted me to go this path and find my mentor, Truman, so that I could do everything under one roof. And that's my friend right there, Truman Baxter. Jim, you've known him for a lot of years as your neighbor. As I like to call him, my friend-tor. He's been my friend and my mentor, coaching me along the way since 2003. In fact, he was in the office the other day and bringing his grandson in to get some teeth removed for orthodontics. And this is him still doing very well. Just a few candid pics from the office. And I owe a great deal of gratitude to Truman. Love it when he comes in and he shakes things up, right, ladies? So before I get started off today, I wanted to give you a little background into what we're doing here. I want to be able to share my knowledge and with all of you. It's been 16, 17, going on 18 years in implant dentistry and reconstructive dentistry, and I feel like I have a lot to give back. And so we are starting the Atlantic Implant Institute, and these two dates, last month and this month, are just a couple of ways to kick that off for what we really want to launch next year. We've decided to set up 6 dates in the future for what I'm calling the Inlet Lecture Series here for local doctors. Here are 6 dinner dates we're planning on doing here at the Cavalier, space pending, still talking to the manager as well. But if you want to save those or contact us later, we will have I wouldn't say a continuum, but a broad spectrum of education. And if you have any topics that you'd like to hear covered, please let me know. But this will all segue into something that is a little bigger. We're purchasing property right now for an institute where we can teach on-site and have a surgical laboratory right there for live surgical demonstrations. Backing up into last month, just a recap for those of you who were here and for those of you who weren't here, just to kind of hear what we went over. Before we go into the all-on-4 neo-arch, we talked about connections last time. I encouraged you to question everything that you hear. Question everything, starting with what's common among dental implants, because we thought that they were all the same, or a lot of people think they're all the same. As I went along my journey in dental implants, I realized that there were far more differences than similarities. They are definitely not the same. And I asked you to ask yourself questions. When you place an implant or when you refer an implant to get placed by somebody, does it matter what they're placing? Does it matter what type of connection they're placing? Do you even get a say? Or do you just restore it because it's what you've always done? I would encourage you to continue asking those questions. In that lecture, we talked about my journey, my primary journey in dental implants, and why I chose what I chose to place from, say, 2003 to 2018. And, you all right? And, there were many reasons, but at the end of the day, none of these implants were really serving me and my patients perfectly. I always knew that there was something better, something to be gained, something lacking. Some of these changes were as simple as I inherited it, to cost, and it was easy. And some of them, as I went down here to these Astros and these Bicons, I thought they would save crestal bone, only to be pleasantly, happy sometimes, but not always happy. It wasn't the end-all, be-all. I talked to you about the stress on dental implants, on natural teeth and dental implants, and where that stress is concentrated. We looked at natural teeth and where the stress is on natural teeth at the top of the occlusion. We looked at the stress on a theoretical one-piece implant that's square in shape. We looked at the stress on two-piece implants and where that stress is located between the junction of the connection between the abutment and the implant. And we talked about how important that was from the way it affected the bone. We looked at these elastomeric deformation studies, these elemental analysis of how that stress affected the bone and what we were doing to that bone when we put a standard implant too deep and the connection was close to the bone and what it did to the bone, and it resulting in that crestal bone loss circumferentially around the implant. And we talked about the history of, I guess you want to call it the blame game. Who's to blame for that bone loss? And for the bulk of my career, it seems like it's been surgeons and restorative doctors pointing the finger at each other, going, well, you didn't do the surgery right, you didn't cool it, there was too much pressure necrosis, improper placement close to the buccal plate, and the surgeon going, well, you had cement there that caused bacteria, you had poor occlusion, everything was fine when it left my hands, so you kind of had this going on the whole time. I established to you last time that the artist was smarter than all of us, because the artist put that old implant above the crest of the bone where it wouldn't lose bone, and then we went and put our first implant too deep. And it was just fate, it was going to happen. So I admitted to you that my first implant I didn't put in occlusion, because it was in implant protective occlusion between two natural teeth, and we still got that result. So in my opinion, I think the connection is the most overlooked factor in all of implant dentistry. I think that we've been given the same story for too long. We've been using the same implants for too long without asking any questions. I think maybe it was the way this implant was engineered all along. And if we could find a better implant and a better way to engineer it and place it, then we could solve a lot of our problems. I think I established that we can't really be ignorant much longer. We have to pay attention to these design factors in these implants, and we have to prescribe what's best for the patients. And I told you that I firmly believe that an implant is not an implant is not an implant. There are far more differences in dental implants than there are similarities. So I would implore upon you to do your research. And I told you that after 15 or so years of placing implants and not being fully satisfied with all of my results, I looked at all the literature, I looked at all my own cases, I drew upon my own experience with the ABOI and the Journal of Oral Implantology, and I happened to notice that these Neodent implants changed from a CM to a GM design, and I looked into that further, and I told you that without ever having placed one, I called Neodent and I said, "Who's my rep?" And they told me it was Max Williams. And I called Max, and he came to the office, and he said, "Do you want to buy 10 implants?" And I said, "No, I want to buy 100. And I have been going with just Neodent implants almost exclusively since then, and I have been extremely happy with the connection and with our results on the bone and our ability to connect anything to it. And I've had absolutely no regrets. Because they put the screw channel deep in the well. They have a Morse taper that locks it in, so you minimize micromotion between abutment and implant. They have a platform switch. And it's one prosthetic platform. So our assistants don't have to dig through the drawers for all the different sizes of red, blue, yellow pieces. And it's a true subcrestal implant. So we can place that below the bone and still get great emergence profile, great prosthetics, great cosmetics. A lot of times in the past, we took an implant that should be above the bone, we put it too deep to try to get that cosmetics, that emergence profile, but we sacrificed our bone along the way. The true subcrestal implant to save the bone and improve all of our aesthetic outcomes. So for me, it was a no-brainer, and I've been very happy with it for a long time. Primary stability is a huge factor in my practice, and we're going to talk about that in the All on 4 lecture tonight, because the ability to immediately load an implant is a game changer. You can't do it in every single case, but you can certainly do it in many cases with these implants because you have a semi-aggressive thread design. It locks in for good primary stability. It's got also good long-term stability as well because at the coronal 2/3 it's fairly parallel. So for my needs, it does everything I have to have it do, everything I need it to do. And it has multi-unit abutment compatibility, which we're going to talk about in today's lecture. Just a couple more about last time. We looked at modern day connections and what that means, getting subcrestal implants and great emergence profile with either pre-manufactured abutments or tie bases. But this is where the rubber meets the road, as they say, because it's all about the patients and delivering outstanding results for the patients with their high cosmetic expectations and our own high cosmetic expectations. And when you have a young female who works in the dental industry who is scared of getting an anterior implant because she knows it's very difficult, and she's so scared that she's had 3 apicos on her lateral incisor trying to avoid a dental implant, and she's only 30 years old. And she comes to you because she wants an immediate load implant, and she knows how difficult it's going to be in her narrow bone. It's because of our experience and because of these implants that we can say no problem. We can take that out, we can put that implant in, and we can restore your hope and confidence for a young lady that's been worried about getting her tooth replaced for so many years. And with that, I'll tell you I don't get paid by that company. Dr. Molinari's here from Andover, Massachusetts. Thanks for being here, Alex. Did you hear that? No, but I firmly believe in that product, and I called them to start using their implants. They didn't call upon me, or Max was trying to call upon me for 6 years, right? So I'm glad that you were able to make the trip to be down here. Incidentally, I found out, I just met Alex Molinari, Dr. Molinari from Brazil, and found out I'm going to Chicago tomorrow to take zygomatic implant course, and he'll be headed there at the same time, so it'd be nice to be able to spend the weekend with you. But with that being said, that was our flow chart for last time, the single implants and connections, and why I chose what I did. And before we get into a case study, I want to take you briefly on our restorative journey, our full arch restorative journey. Of course, you can't start any full arch without placing a couple of single crowns and a couple of quadrants. And I think a great place to start is with your 2 implant overdenture. Let me back up. As I go through this, I tell you this because I don't want you to think when we get to the end of this that every case is a full fixed, all on X case. Different patients have different needs, and treatment modalities need to be designed for individual patients, not for what we want to do. So all of these treatments need to be in your arsenal and in your thought process as well. So going back, the 2 implant overdenture is the most simple and basic restorative, full arch restorative concept that you can provide for your patients, the most economical, if you will. And in my mind, maybe the minimum standard of care, even above a conventional denture. It involves 2 implants, typically in the lateral incisor areas of the mandible, and an attachment that goes over top. You might know them as locator, you might know them as Novalock, but they go over top, and you have to be able to make a perfect denture. This will not make a bad denture good. This will make a good denture better. So you have to first be able to make a good denture. But we did a lot of these over the years, and we still continue to do some, right, ladies? They're not for everybody, or full arches aren't for everybody, so you have to be able to do these. In fact, we took an impression for one late yesterday afternoon. But that is a staple of full arch restorative dentistry right there. The next step in my mind is an implant supported and implant retained overdenture. Typically, that involves a bar attached to 3 or more implants, 3, 4, 5 implants. This denture is implant retained but tissue supported. That denture, depending on the extent of the bar, can be implant retained and implant supported. So we still do a lot of these today, less than we used to, since we've been doing more full arches on fixed. It's a great treatment plan for those patients that don't have an ideal skeletal relationship between maxilla and mandible, or the AP spread is deficient. That's a fantastic treatment as well. Say somebody comes in for an all-on-4 upper, but they have a poor AP spread in the maxilla and they want to avoid sinus lifts, maybe they can have a bar right there and a denture that snaps in and out. I think it's fantastic. I call it a semi-fixed solution. Depending on the extent of that bar, it won't move. Moving on in our full arch implant journey, we've got cases like these, and don't snicker. I know it doesn't look pretty at this point, but that is a work in progress over 20 years. All right, that's a patient with Sjogren's syndrome who wants to hang on to every last tooth, and every 2 or 3 years they're coming in for another implant, or 2 or 3. And you end up with an encyclopedia of dental implants going back to 1988 or 1992 or whenever it started. Everything from Stereos implants to Zimmers and Bicons and Actives, and there's a press fit implant in here too. And he just did not want to lose that last good tooth. So it was a psychological thing. It was a good tooth. In his mind, it was a good tooth. because it was there psychologically, and he was very happy to keep it there. And George kept that tooth all the way to the end. Good friend of mine. But you get involved in these cases, and you just do a few here and there, and that's sort of what you end up with. And in the conventional dentistry way, where you didn't do teeth in a day, you might plan to go somewhere like that. Maybe not with so many implants these days. Maybe with 5 or 6 or 7 or 8 implants, but that delayed approach where you extract teeth and graft and maybe place the same day. Maybe you go back in 6 months or 4 or 6 months, you place implants. And then you come back and the whole case takes 12 or 18 or 24 months. Those can still happen for some patients. But that type of treatment might cost double what a full arch teeth in a day costs. That type of treatment, you might be looking at $80,000 or $90,000 in his mouth, easily. I mean, I've had cases, I can think of one case, Ray, years and years ago, I think he went up to $115,000 in his mouth over a course of a couple of year period. And compare that to that's just more on George here, but compare that to our full arch teeth in a day, which can be 25,000 an arch or maybe 30, and so it's half of the old way of doing it. Who remembers Ross Perot? Candidate for president, was it 1992? 96 maybe? I love analogies, right? I love analogies. Ross Perot, whether you love him or hate him, you got to laugh. He always had an analogy for everything, This guy could be talking about like global economics, and he'd be like, you can't count the cash in a haystack until mama puts hot food on the table, or something like that. It's like, you're like, what? Sometimes they make it, maybe only farmers could understand that. I don't know. But I look at this like a car analogy. You can buy a car every 5 years for $20,000 or $25,000. Over the course of 25 years, you spend $100,000, $125,000. Or you can buy a good car for $50,000 and drive it for the 25 years. So maybe it makes a little more sense than Ross Perot's analogies, I guess, I hope. So all of that journey over the last 15 plus years eventually led me to wanting to do more of this. Something that's, in my mind, a lot easier to do, more beneficial for the patient. It's sort of more economical, cheaper over a lifetime, and you get more satisfying, better, quicker results. And that's the subject of our lecture today. So what is an all-on-4? All-on-X, all-on-5, all-on-6, whatever you want to call it. The bottom line is that it's a graftless treatment protocol for a full arch immediate load. Graftless treatment protocol. Because if you were to need to do grafts, you'd be doing sinus lifts, you'd be doing onlay posterior bone grafts, you'd be extending your treatment to 12, 18, 24 months. This is a graftless solution. It is just one way to restore an edentulous arch or a patient with a terminal dentition. It is not for everybody. The patient must have sufficient bone, and they must be medically qualified. And I think that above all, the patient must take ownership of their situation and be compliant. So a quick history on that. Where did it all start? I guess for me, it started around 2003 when we started looking at literature from Paulo Malo, and he was talking about his results. Apparently, he had been doing it for a while with his partner Rangert, because he was looking at retrospective studies in longevity in the mandible in 2003, and in 2005 again in the maxilla, reporting 98 and 97% success with his all-on-4s. It's interesting, 2003 was the year I did my residency at Portsmouth Naval Hospital. And Portsmouth Naval Hospital, the general practice residency is very heavy into surgery. and oral surgery and periodontics, but it also has a great pros program. I had an oral maxillofacial prosthodontist there as my mentor, Captain Alfano, and I had to do a table clinic that year for the hospital. And Commander Alfano suggested that we do teeth in a day because it was hot, it was brand new in the literature. In fact, so this is my table clinic, and I found it in my attic. And it didn't even turn yellow, so that's excellent, excellent table. So I'm not that old, Tiffany.
That's a good low acid paper.
So he suggested we do teeth in a day because we wanted to be on the forefront of something novel and brand new. And we wanted to do something great for our veterans. So I was a baby dentist. I guess I was off and running quicker than I could cut a class 2 amalgam preparation. We were talking about teeth in a day. Who knows the author, Dr. Gawande? Untitled Gawande wrote The Outliers, Better, right? Checklist Manifesto, one of my favorites. Now my staff knows why I'm huge on checklists. Checklist, all the time. He wrote a book called Complications. Complications, a surgeon's note on an imperfect science. And I think he wrote in there, he asked the question, do we ever tell our patients that it is our first time doing a procedure? And that they might be in better hands with an experienced surgeon. Right. Well, I would tell you that with this patient, you're damn right we did, because we told him it was a brand new procedure and he was all in. So there's our poster board presentation right there. This is the situation. In prosthetics, we always call our current set of teeth the situation. All right? It's not anything quite as hostile as your Jersey Shore situation. But this is Sergeant Major right here, Marine Corps. I was in the Marine Corps. Obviously, we had a great bond, and he was willing to go through this with me. In that day, we did this as a 2-stage procedure. We wanted to establish occlusal vertical dimension with a denture. We wanted to take our time, make sure we had all that right. I think we would do that drastically different these days. So just I can't get over how different this is from how we do it nowadays, but we put in parallel implants, all anterior to the foramen. I don't think we worried so much about AP spread. We had a real denture with real teeth on there that we cut out to pick up. We did alveoloplasty, probably more for the oral surgeon than for the prosthodontist. You know, I wrote on there that the implants were verified for draw. I mean, who does that anymore? That's not even important. The surgery department picked the implants, and they picked these short 10 millimeter implants, 10 or 11 millimeter implants. Alveoloplasty was decided by the surgeon based on the width of bone so you could put the implants in, not necessarily by the prosthetics. The pickup material of these dentures, you know, I think we use jet acrylic, which I don't even want to guess what the coefficient of thermal expansion is on that, or the contraction over time, stability over time. But it was 2003. I mean, I think we were working in the dark ages at that time. So, I mean, I was proud of this case. I was proud of this case for everything that it was and everything that it did. But I don't think at that time we fully understood all on 4 principles. You know, we pulled it off. At first, I mean, it was successful for a while. And we had a great team of surgeons and prosthodontists on that. I think we had 3 oral surgeons on there, 2 prosthodontists. We had a team of oral surgery residents. You know, we were all doing our best there. But unfortunately, I caught up with Sergeant Major a few years later, about 8-9 years later, and I realized that it didn't last. It didn't last. We didn't know what we didn't know. And that's always a dangerous place to be. I mean, it was still early. It's 2003. Sergeant Major, he was fine with it. He said it got him a few good years. But we didn't know what we didn't know. All on 4 does not mean simply putting it all on 4 implants. There is a big difference between all on 4 and teeth on 4 implants. The bone reduction wasn't really planned for prosthetics. The implants were too short. They weren't engaging basal bone. I thought when I watched that surgery, I think I could smell bone. Because there was so many chiefs in the room, not enough Indians, and everybody was just trying a little too hard. I mean, don't get me wrong, I don't want to say anything bad. Portsmouth is an outstanding teaching hospital, and I had a great education there. But we didn't know what we didn't know. And the main thing we didn't know is that all on 4 is not a surgical procedure. It's a prosthetic procedure. And the planning has to be around the teeth and not around just the bone. I bring that up. I think it's important to admit your mistakes and how you came to this point, because I don't think any of us become great without having a few diversions along the path, and finding out what works. But I also bring that up because it affected my career for a long time. For 10 years or more, I didn't think all on 4s worked. I didn't think that they would ever be successful, and I sort of laughed at people who talked about doing them. From 2006 to 2012, the literature, the news, the internet had stories of failing doctors and failing patients, with a few speckled success stories along the way. You got this doctor boasting 98% and other people talking about 50 to 80%. And, I decided to sit back and watch and learn. And I said, with time, everybody's going to figure this out. But we have to figure out why we're having failures. I mean, for a time, I was working for attorneys as an expert witness for trying to defend dentists doing their best work. And I was getting calls left and right trying to defend all on 4 teeth in a day cases. And so that was nothing that I really wanted to get wrapped up in. I mean, I was asking myself, why did some doctors have bad results and others have great results? But there was some hope on the horizon. I started to see better literature come out, 2011, 12. We start to see Malo comes out again. Now he's not talking about a few year studies. Now he's talking about 10 or 15 year studies. And he's talking about losing 21 out of 980 implants and prosthesis success rates of 99.2%. So you start to think, well, what is he doing? You start to see published literature about what is successful, the parameters for success in the prosthesis. 2012, cross-arch stability and micromovements. What is the interim prosthesis made of? The definitive restorations, were they inserted immediately? Screw retained over cement retained, the occlusion, and the number and distribution of implants. Journal of Prosthodontics. Somebody finally starts talking about maintenance and care of these things. It's not just get your teeth in a day and go home. It's get your teeth and then come back. And we've got a few staff in the back and our hygienist, and we call them back how often? Every 4 months, right? So we call them back every 4 months to make sure we take care of that. Then we start to see 30-year follow-ups coming out in 2017, 18. We see 30-year follow-ups, and I start to take notice that these things can last, that there must be a way to do it. And as I look at a 30-year follow-up, there are many principles of all on 4. And one of them that I think is paramount is long implants in basal bone. You have to be willing to go deep. Because in my mind, alveolar bone has a different metabolic rate than basal bone. It's not as strong. It's different all the way through, from cellular to macro anatomy. It's different all the way through. And we have to engage that deep bone. I look at Instagram and other doctors on Instagram, and they post these all-on-4 cases with these short little implants, 4, 5, 6 in the alveolar bone. They're 8, 10, 11 millimeters long, and nothing even goes below the mandibular canal, even in the anterior. And they're very proud of their cases. And I want to invite them out to Virginia Beach in the summertime on a windy day and say, put in your beach umbrella 8 inches and see what happens, right? Because if it's me, I'm going to put it in 2 or 3 feet. So we start to see these literature with these principles, and I'm taking notice and reading, and I say, well, maybe this is something we can do. 2000, I showed you a little bit about this, but just going back, I did a lecture in Bologna, Italy, and I was asked to lecture on success of dental implants and bone grafting, and in a private practice setting. That was the topic of the course. And so I looked at my own, and I looked at my success at that time, and I went, and when I added it all up, I went, wow, it's only 94%. I thought it was way higher. So it really bothered me. So I started looking at every single patient that had a failure. And I saw cluster failures. Multiple implants failed in the same patients. And then I started looking at medical histories. And at that time, I wasn't making certain patients go get A1C checks for diabetes. But I started to notice that if I'd see implants fail and then find out later they were diabetic, uncontrolled, right? And I learned that if you threw out those unhealthy patients, the ones that we found were unhealthy later, or you threw out those cluster failures, which is a term, by the way, you should look up, a cluster failure. That's multiple failures in the same patient. It does exist. That success rate jumped to 99%. So health, I don't want to get into it too far tonight for limited time, but health is extremely important when selecting our patients. We can't just do these on everybody. We have to look at their overall systemic health. We have to be willing to say no to some people, or to say not yet, go get healthy. You have to be willing to exclude people, which by the way, as an aside, I think is always interesting in the literature when you see somebody's studies and they show a low success rate, but then when they say, well, when we throw out these patients, we're really high. And that's kind of essentially what we were doing in private practice for so many years. You have to look at your inclusion, your exclusion criteria, and you have to put that on the forefront of your treatment, deciding who you're going to treat and when. You can't just go ahead and treat everybody.
Would you put smoking in there?
Smoking is very interesting because it's very hard to treat patients in Hampton Roads if you exclude all smokers. So I know a lot of people have a different way of handling smokers, from doctors who say, if you smoke, I won't ever touch you, right? So we counsel our patients on smoking and its effects. And the way I say it, my staff is probably tired of hearing me say it this way, is that 90% of smokers are going to be fine. 90% of my problems are going to be in smokers. So if you're going to continue to smoke, you're going to take your own risk. And we document that. So not quite as much. It's more of a local irritant. I certainly I wouldn't want to be placing implants in an area where somebody's doing chewing tobacco while that implant's healing. But excellent questions. I don't think it's an absolute contraindication, but I think the patient has to be informed. In many cases, we convince patients to stop smoking they say, how long do I need to stop smoking for? Well, I wanted to see the soft tissue closed before you smoke at least. How long is that going to take? 6 weeks. Okay, I'll quit for 6 weeks. Okay, well, can you quit for 6 weeks in a day? Yeah. Well, can you quit for 7 weeks? Probably. Well, I quit once before 5 years ago. Well, this would be a great time for me to quit again. Yeah, exactly. If you can quit for 6 weeks, you can quit. So, but that's a great question. So around 17, 18, everything was coming together, and I noticed Neodent, GM implants, and I wanted to take on the full arch, teeth in a day, more regularly. The long-term studies were there, success and failure, reasons why. I was understanding now at this time. I was understanding exclusion and inclusion criteria. I had had ample experience placing implants. And I decided it would be a great time to jump in, but I couldn't really jump all in without also having a dental laboratory on site to support. Because in my mind, that was one of the issues that was keeping me from doing this on the regular, having to hire a laboratory to come in for a day and handle these cases, and then knowing that they wouldn't be there if the patient came back the next day with a problem. It would be all on my own. So I wanted to be able to bring in a lab at that time. So that's when, Alex, that's when I contacted Neodent and got with Zircon Zahn as well. And it's been an adventure, but it's been a great adventure. So here we go. All-on-4 is now a main staple of our practice. Not the only thing. We also do a lot of singles. But these are just several cases of teeth in a day. These are all provisionals, if you will, taken after surgery. We convert patients probably most every Wednesday and Friday, and it looks like it's growing, so it's becoming a major portion of our practice to what is in the tune of about 150 arches a year right now. And I think we're learning something new with every single arch, and it's exciting. But I just now, after a few hundred, I feel like we're finally understanding it pretty well. And a lot of it's because of this. And I said it before, an implant is not an implant is not an implant, and an all-on X is not an all-on X is not an all-on X. You have to understand those principles. This was a patient we did just a few weeks ago. These implants in this maxilla are all 16 or 18 millimeters long. They're all engaging basal bone. In many cases, I purposefully engage the cortex, the junction between the bone and the sinus or the nasal floor, because that's the hardest bone available. And I do it routinely, trying to keep implants palatally, if at all possible. That same patient, I said an all-on-4 is not an all-on-4 is not an all-on-4, right? Same patient in her mandible already had an all-on-4. And this is her existing all-on-4, which is actually 5, I believe. And these are my planned implants over top of it to replace it. Because even though it's only been 2 or 3 years, she's had nothing but breakages and problems with her bridge. And she's got 1 implant that's completely not integrated and 2 more that have 50% loss of bone. And it's all because the doctor just thought that if they place 4 more implants, they can do an all-on-4. But what do they have? Short implants in alveolar bone. She's agreed to let us restore her bottom. That's Rosetta. She's agreed to let us restore her bottom. And we're going to be starting our implants where the other implants finished. And that's very typical. We start our implants where the teeth finish often. And we'll be able to place 18 millimeter implants in most of those sites. And we'll be able to surgically guide an implant around the mandibular canal for a much more stable result. That's just a comparison of where they were versus where they should have been. And if they were placed there in the first place, she wouldn't have had those prosthetic problems. I'll let you hear her tell the story for herself. You had your lowers done somewhere else.
Yes. It wasn't nice. Where were you?
I've been here the whole time.
How many years?
Maybe 18?
You could have done it. I would have been in good shape. Yeah, this is great. I mean, from the day I walked in, it was been like heaven. Seriously.
Thank you very much. I love her. She's great. Not just because she says nice things, but she's a genuine nice person. But she's just talking about the difference between, you know, going somewhere where they just try to do all on four and going somewhere where they do a lot of all on four, basically. Patients always ask two questions. How much is it going to hurt? And how much is it going to cost, right? So most of our patients take Tylenol, extra strength, and Motrin 800 for 3 days. We prescribe a narcotic, about 12 or 15 or maybe 20 narcotics, depending on their anxiety of postoperative pain. And most of them tell us they just take a day or two.
If I had someone come in who's scared to have the surgery done, what would you tell them?
Hey, get Dr. Hogan. He's man. I mean, I only took one of the narcotics, 1 or 2. And I still got a whole bunch of ibuprofen.
Feels pretty
So-
good.
I feel great.
So that was was that the 3 day after or the 3 week?
That's the 2 week.
2 week. That's 2 weeks after surgery. Okay. Yeah. So that's very typical. I wanted to have you hear it from a patient because I tell people that all the time about Tylenol Motrin. No one ever seems to believe me, but we hear that story all the time, very frequently. So let's get into cost. Now, frankly speaking, the surgery runs about $20,000 an arch with sedation. That covers everything right up to your restorative phase. So it's all the pre-diagnostic work, your surgery, your sedation, your basic bone grafting. Maybe sinuses are extra, but your basic bone grafting is covered, and all your follow-up visits. Wes, you asked how many visits is that? I mean, we usually see people 2 or 3 times before surgery, and we have 5 visits scheduled after surgery for 4 months. So all that's covered. When we get into final zirconia arches, you guys are probably charging 12 to 15 or 16 per arch. Our lab, if we do it for you, is currently gift wrapping that for about $5,000 per arch. So, but you'll see what goes into that. But I know some of you out there saw that $20 or $30 or $50,000, and you might have shuddered a little bit. So I wanted to say for some of the doctors in here who don't talk about high fees a lot, or the staff in here, I would say you have to be prepared to present this to your patients. You have to be confident in the number, all right? You have to know that just because you can't afford it right now or you don't think it's valuable right now, it doesn't mean the patient can't afford it or doesn't think it's valuable, right? I mean, who are you to decide what's best for them or what they can afford, right? Don't make assumptions about the patient. Don't judge what they want. Don't make assumptions about what's in their wallet. I've heard in the past staff, they talk about anything from all on 4 to fluoride like it's too much money. You know? It's like, how much is that? It's $17. You probably don't need it. You get a sandwich for that. And they'll do the same thing with your all on 4. But it's worth it. Don't presume that they'll be better off in a partial denture just because it's cheaper and quicker. So have confidence in it because you never know what it means to them. All on X is inexpensive, not expensive.
No, they are cheap. They are
I'll tell you briefly, I walked in the room and I said, "You look pensive." And he said, "What?" He said, "Did you call this expensive?" So we got on this expensive. So he goes, "Yeah, it is expensive, but listen to his words."
No, they are cheap.
Cheap.
They are cheap. They are. Oh, you know why? You know why these are inexpensive?
No.
Forgive the
Because you
camera.
got them done right.
Well,
The first place.
Look, I figured that out from the
Yeah.
start. I could do something like this every 3 years for the rest of my fucking life. I'll get it done now.
Get it?
You hear what he said? I could do this dentistry every 3 years for the rest of my life or just get it done now. Right. You know, you guys have patients that come back every 3 to 5 years putting another $5,000 into their mouth, you know, which is great for a little while until it's been 15 or 20 years and they're going, I looked and I spent 30 grand here and I've gotten nowhere, right? And then that's a hard discussion to have, right? So tonight I want to take a look at our friend John for the rest of this presentation. John came to see us in December. This is a very recent case. In fact, so recent it's today. John came to see us in September with this malocclusion. Chronic severe periodontitis, anterior open bite, crowding, splaying, rotations, cross bites, class 3 skeletal, bruxism, grinding, increased OVD, which we don't see quite a bit. We don't see a lot of excess bone. Just so we covered it, medical history is pretty clear. All right. I ask everybody, are you diabetic and are you a smoker, whether they write it down or not. All right. He denies both, and I write that down too, denied. So we've got that covered. Looking back at John, his occlusal views, and you can see what we're dealing with. All right, it's almost too much. It's a lot, right? This excess bone and displaying of teeth, the anterior open bite, the bony exostoses, sublingual tori. You know, as I'm looking at this case, I'm thinking, you know, one, you're blessed, and one, you're cursed, right? Because there is a lot of bone there. So we've got a lot to work with. We also have a lot of work to do in surgery. A lot of work. These 3D CBCT renderings kind of show it. That very long chin, all the excess bone. You know, these teeth are not going to be fun to remove. We're going to have to take our time in many respects. As you look at those slices off the cone beam, you think some of those will be easy, and some of them are surprisingly not. But fortunately with John, we've got a lot of bone to work with, which is great. Because he's open, we're going to have to take a lot of bone away. His maxillary teeth, this is posterior cross sections of his maxillary teeth, and while the mandible looks quite simple surgically, except for the time involved in removing all that bone. The maxilla, we look up here, and we've got minimal bone in these areas. All right, from premolar to molar, I think this is a 14 area. And we notice number 3, look at the size of that chronic cyst, that chronic infection right there. His anterior maxilla looks slightly more promising with a little bit of length. We can remove these and start placing implants at the apices, and we can probably be just fine. Looking closer at that right posterior maxilla, we know that we can see what it looks like even before we do the surgery. We know that it's 12, 15, 20 millimeters across up and down, but we know that we're going to have an oral antrofistula right from the get-go. And I also know that I might be compromised in my AP spread right here. So we tell John that there's a good chance we can't load the upper on the day of surgery. There might not be enough AP spread. We might not have enough stability in the back. You have to be prepared to leave in a denture, and we're going to do a sinus lift, at least on your right side. And if we can load your upper arch, there's a good chance the bridge will be a little short on that upper right side. And there's a good chance you might come back. Given this size of this sinus, that sinus is going to take 8 or 10 or 12 months to be ready for an implant. You might wear that short bridge for the better part of a year, and then we'll put in an implant and perhaps load it at that time. So John says, sure, that's fine. I'm ready to accept that denture. So we're not ready for surgery yet, because this is, like I told you before, this is not a surgical procedure. This is a prosthetic procedure. We have to do a smile design, a smile analysis, and a smile design. And I have to work in conjunction with my laboratory, who has just walked in the room at some point here, Mr. Rodriguez, and Karina in the back. Anybody else from the lab here? I don't know when you snuck in, but good to have you here. So we have to work in conjunction with our laboratory, and we have to design the perfect smile. Now, he's got a bit of a high smile line, and he's open vertically. which is a more rare and peculiar problem. We're looking for his facial midline and his horizontal plane of occlusion. And we're looking in his mouth trying to find at least one good tooth or one group of teeth. You have to look at the whole picture as a whole. It's a piece of art. It's not one tooth at a time. It's a piece of art, and we're looking for the very best tooth. So we've got him on a Coy's facial analyzer, and we take our measurements, and we look and notice how far open he is. It looks like 8 or 9 millimeters, and the slender, small teeth relative to his facial dimensions, and his side profile, and the proclination of these anterior teeth. And you step back and take a look, and you have to decide where you can put those new teeth. And for me, I'm fortunate that our laboratory is in the building, and they get to meet the patients and go in. And when we met him, it was just like, blows your mind. You know, where are we going to start? But I'm fortunate enough that with our laboratory technician back there, our master technician back there, that he and I think very, very similar. So there's never a fight over where we're going to put the teeth. And he says, I like that canine. That's it. Just, I like that canine. And I step back and I say, absolutely. Canine's perfect. It really is. With that midline, right there. Canine and that midline. And we're going to set a maxillary arch, and we're going to then design the mandibular arch to match. And we're going to close them up. The beauty of this whole system is that when Mr. Rodriguez and I get together and he designs a digital smile, and then we merge it with his existing, and then we bring it to the cone beam scan and we bring it in, I can see exactly where I need the implants to support that new smile, not the old smile. So we merge them and we bring them in, and we know where the future incisal edge is going to be. We know where the implant needs to be, right? It's pretty simple. It takes a lot of work, but it's pretty simple. It's a prosthetic procedure, not a surgical procedure, and the prosthesis guides the surgery. So we do our planning for the mandible, and we look at how much bone we need to take off, and we do our planning for the maxilla. Now, I showed you earlier that there wasn't quite enough bone in the posterior maxilla at that time, but a little trick I've learned along the way is that when you can't to the mesial and to the medial, you frequently find bone, palatal bone, right there, which is one of the reasons that we get multi-unit angled abutments in place later. We planned them in the anterior mandible, and you see where the trajectory is going to land relative to the current teeth. So not to spoil anybody's appetite, hopefully you're mostly done, I'm going to show just a few surgical slides. Fortunately for you, I didn't have a lot of surgical slides on John, so it's going to be short. We do these surgeries typically under general sedation or IV sedation. A lot of patients will do local for one arch, but generally they're under general anesthesia like John was. There's the exodontia and the removal of any pathology and the alveoloplasty, and that's not to be taken lightly. These teeth can't just be ripped out. We take great time in removing the teeth to save the bone. So, you know, I go in there, we section off all the dental materials, and we section all the multi-rooted teeth before we lay flaps, and then we start removing buccal bone down to where the alveoloplasty will be to make the teeth easier to remove, and then we remove teeth, and then we get the alveoloplasty down low enough for the prosthesis. With my dental implant placement, I like to start in the anterior because I get to feel the density of the bone. This is all about primary stability of these dental implants. And for me, there's a huge factor in the feel of the bone, knowing how dense it is. And the anterior maxilla is very forgiving, and it's a great place to feel what this patient's made of. And then we go posterior to our posterior extent, and if I can place implants in the middle, I do that as well. And then it comes time to pick up the teeth. And we make, for those that aren't fully guided, we make a cleared replica of the existing teeth, and we have to select multi-unit abutments that are as close to that incisal and buccal corridor as possible, so that these multi-unit abutments don't come out the facial, causing some cosmetic crisis, or they don't come too far to the lingual, causing the patient to have problems with their speech and impede on their tongue space and whatnot. So that is a huge step in the surgery. I mean, if it takes us 45 minutes to place implants, it might take us 40 minutes to pick MUAs, because the patient's generally going to live with those MUAs forever, or you're going to have to spend a lot of time removing and replacing them correctly with new impressions and new records and whatnot. So it's very important. So the teeth go back to the lab for Mr. Rodriguez and Karina there. And while they're there, we correct all the bone deficiencies, and we tidy up the alveoloplasty a little bit, and we do any necessary bone grafting. This is where we went back into John's sinus, and I did a sinus lift in this area, because I thought that I was going to return here later to add an implant to improve the AP spread. And then it comes down to wound closure, and I use platelet-rich fibrin. In that upper slide, this is fibrin taken from the patient's autologous blood supply. That clot is loaded with white blood cells and stem cells and growth factors to speed and healing. And then it's very careful, meticulous placement of keratinized tissue around the implants. And by the way, that starts with very careful, meticulous dissection at the beginning, so you don't get any tears and you preserve tissue maximally. So the teeth come back from the lab, we insert them, and we evaluate the occlusion, and then it's time to take a look at them and go through post-operative instructions, and we set 5 appointments. The first appointment is 2 days later. I'm going to do an exam, head and neck exam, and make sure that they're getting along okay, just looking primarily for signs and symptoms of infection and making sure we have adequate pain control, and double checking the occlusion. This is John after 2 days. I apologize, I did not have a full facial shot, which is standard, but we missed it on that case, but these are his lips and his teeth on that day. I will tell you that he didn't have any significant swelling. So our second visit comes about less than 2 weeks later, when we want to take records for a new set of teeth, and we want to remove the sutures. So this starts with evaluating the teeth and his smile. This is his day of surgery teeth, right here. And you can remember his malocclusions and where he was at. And we got the canine in the right place, right there. So upper arch is looking pretty good, but we can improve upon this, but that's all a process. So we go back to records. And records starts first with making sure the patient's comfortable and the bite's stable, and then we go into the photo lab. And in between the photo lab and this step, we take face bows and bite, and then we take the teeth out of the mouth so we can scan them so we can start to make changes. This is John's suture sites at less than 2 weeks, probably about 10 days. And we've got the mandible and the maxilla here. And this is after removing those stitches. As a general protocol, my sinus lift, we keep those stitches in more than 2 weeks, closer to 3. We want to keep that closed up. So those stayed in for a few more days. But that's a typical appearance after a couple of weeks. On post-surgical visit 3, that's 3 days later generally, 3 to 5 days later. We're still less than 3 weeks out. Because we have, in the last 3 days, we designed a brand new set of teeth to improve cosmetically and functionally on the first set of teeth. So this is John as he's leaving less than 3 weeks out. And we've corrected the plane of occlusion we thought we were showing too much mandibular teeth originally, and we wanted to bring him down in the maxilla and in the mandible as well.
Yeah, they're awesome.
Just to kind of get you used to
Yeah,
well dressed
yeah,
small things later.
yeah, very nice.
You can imagine, you know, what's going through John's mind from where he was at 3 weeks ago, right? You know, it's just, I think his mind is blown. It's just, they're very nice, but super appreciative of where he was at. You know, from here, we tell the patient to go home, relax, rest, heal, eat soft foods, and call us anytime, but we'll see you in about 6 weeks. All right. So this is our 4th visit after surgery, about 6 or 8 weeks later. We schedule him with the hygienist, who will go over oral hygiene instruction and clean up around the bridges and take radiographs. I want to evaluate all of my implants about 6 weeks after placement to make sure that they're getting along okay. We do that for every implant, singles and full arches. That's a great time to intervene if you should see a problem. It's also a great time, midway point, to check and see that they're doing all right and remind them to eat soft foods. So these are his radiographs at 6 weeks in the mandible, and this is a typical appearance. We see good radiopacity around all the implants slightly subcrestal where I put them. These are the MUAs. If you're not familiar with seeing MUAs, those are the MUAs on there, the multi-unit abutments. We're going to see more of those today. And the maxilla. These are all good radiopacity around the implants, slightly subcrestal, seeing some of the membrane that tacks the window to the sinus in this area. And looking at our cone beam slices, looking at very long implants. I mean, there was a tremendous amount of bone, and these are 18 millimeter implants. So we've got excellent stability. When I place those implants in surgery, I'm aiming for every implant to be 45 to 60 Newton centimeters in strength. All right, it's very typical that our full arch has over 200 Newton centimeters altogether. So we get very good stability of those implants. And in case you were curious about the sinus, the results of the sinus lift, we went from gross pathology and destruction of the buccal plate to growing, at this point in time, nearly 19 millimeters of bone. So it's looking good. At the 5th visit comes about 16 weeks after, or 4 months, and this is a typical records visit, all right? And we're going to go through this in detail because many of you, some of you that have referred us arches, you guys go through these same steps as well before you restore them. But it starts with a patient interview, doctor and team assessment of the teeth, your chair side adjustments, exams, radiographs, and then you go into FACEBO, bite registration, photos. We remove the teeth. You know, we check the proper MUAs that we want to be on there for a lifetime, make sure that they're correct, change them if necessary. We torque them all down, 20 Newton centimeters. We're going to put on a verification jig and visually inspect it and inspect it radiographically. And we'll make an open tray soft tissue impression so that we can get our new bridge to match the soft tissue of the intaglio surface there. And then you send it to your laboratory with any prescribed changes. So, step 1, how do you like your teeth? What do you think? How are they functioning? Are they comfortable? Are they long enough? Are they white enough? Are they big enough? Are they small enough? That kind of thing. You get to get a feel for their cosmetic expectations. When you go and look at the patient, you want to stand this patient up in front of you. All right? This isn't the time to be looking over their shoulder at 45 degrees from behind, trying to guess if the midline is on or how long the teeth are. Get them up in front of you, 6 feet away, and just get an overall picture of how it looks. And for the team, this is not the time to be making the little tiny comments about what you don't like, because you might put an idea in their head that they never thought of before and they'll never get it out of their head. Okay? So have those conversations in private. with your doctor, all right? Chair side adjustments. We want to make sure that the occlusion is stable, all right? And for your patients that are coming back to your office, we've probably already looked, but I ask you to do that again. Make sure that they have a stable occlusion. Make sure that when they bite down, they're not compensating for a slide, which patients will learn how to do. John, before we met him, he had an unstable occlusion. He was sliding into his bite for 59 years, he thought it was normal. You got to make sure that they don't hit slide and then say it feels good. They got to stop when they come together. You have to make adjustments until they do, if you can. You can treat these teeth very much like a wax rim if they're too long. You can shorten them down, you can contour them on the side, because every little bit that you do to show us what you need would help. You can't make them longer though, so you take off very judiciously and very conservatively. And then you go to taking a FaceBow. We use the Coy's facial analyzer with Panadent articulators, and that is an absolute process. Now, for you know, or you should know, that this is not as simple as just pressing this up against the teeth and recording it. You're putting this where you want the plane of occlusion to be. So if there's a cant in the plane of occlusion, you'll have an open side on your bite tray, on your analyzer. If the midline is off, you put that where you want the midline to be. So a lot of thought has to go into that, and it's best done if you're sitting right in front of the patient or standing directly in front of the patient, looking at them at eye level, and the patient is all square and level as well. Show you this a little bit here.
For me, and I'll do the rest, okay?
Explain what you're doing, Karina.
So I am not going right now by the line right here because I have already, smile for me, sir, midline and center. So I'm not searching for the midline. So if I would have searched for midline, I'll go by the laser right here to match in here. So what I'm going right now by vertical occlusion plane. So I have occlusion perfectly aligned in here, and I have a bubble in the middle. So I'm very pleased with this because everything is nice and even. So if I had to find the midline, then I had to make sure my laser matches to this, and my bubble is also level.
Perfect. I didn't know you were going to be here, Karina, but you're doing a great job. You're going to be famous. Oh, that doesn't want to play. Hold on. All right, well, not that famous. That one didn't want to play. I apologize. Hang on a second. Let's see what's going on here.
So I have occlusion perfectly aligned in here, and I have a bubble in the middle.
Not much.
So I have occlusion perfectly aligned in here, and I have a bubble in the middle. So I'm very pleased with this because everything is nice and even. Open up for me. And so before I'm gonna
Now,
I want to make sure that
we're going to talk about the next step, bite registration. Sorry, I was having a little computer problem there. They didn't want to play. Hopefully we won't have any further problems with that. But bite registrations, you know, it seems a little ordinary or mundane to talk about that because it's just so easy to have somebody open up and just, you know, squirt some material in there and say bite down and don't open and turn around and do something else. But it's so much more than that. It's very important to get a very stable, accurate, repeatable bite on these cases. If you don't do that, you're going to end up with remakes and excess chair time. And that's very expensive, as you all know. So pay attention to how she explains this, because she does it very well.
open up for me. And so before I'm going to register a bite, I want to make sure that patient is occluding in the proper occlusion. So open up for me and bite down. bite down all the way. So right now patient is biting incorrectly. So I have to make sure that patient is biting on the posterior teeth. So let's try it again. Open up for me and bite down again and open up. Sometimes when patient has a trouble to occluding to the proper occlusion, we want to ask patient to put the tongue to the roof of your mouth and try to swallow and bite down all the way, just like that. So when I see the patient almost getting to the 3 times or several times to the same occlusion, I already know exactly where I need to register. So first I'm gonna register on one quadrant and then I'll wait. Open up for me. And bite down for me, sir. Perfect. I know that he's occluding properly because he gave me several times the same occlusion. So I'll wait until
So
this
it's
sits
a dual
up, and
bite.
I'll do the same thing on
You
the other
notice she
side,
didn't
keeping
just
this
put it
bite
all the
in
way
place.
around and have him bite into it and walk away. We put it in on one side and we come back.
So before I'm gonna register a bite, I want to make sure that he is occluding in the proper occlusion. So open up for me and bite down all the way. So right now patient is biting incorrectly. So I have to make sure that patient is biting on the posterior teeth. So
Hang on, same one? Okay.
just a second. All right, so what I'm gonna do, I'm gonna ask patient to bite down several times on the same bite. Open up and bite down to make sure patient is occluding in the same place. Open up and bite down. Open up bigger for me and bite down for me. And I see everything is perfectly. I do the same registration on the other side. Open up for me. Applying the bite on the occlusal surface, not lingually, but evenly spread it. Bite down, just like that. So you see patient is biting in the same place and here as well. You don't want to bite too much buccally, too much lingually, and not too much of the bite. You want to put enough that it's registered, because when you articulate the case, you have to trim it anyways.
Perfect explanation, Karina. I don't think I could have explained it any better myself. Definitely not without the patient. It's important to see that process. So then we go into our photo lab and we take pictures. You see this ring here and this backdrop? Other than having a great camera, that's a big added bonus to great pictures. But I'll tell you, if you don't have that ring light, by the way, that ring light's only about 40 bucks, maybe 50 bucks right there. But if you don't have the space for that, they make these fantastic ring lights right here that clip right to your iPhone. And iPhones take great pictures, especially if you have the newer ones. And you've got regular daylight, you've got color corrected light, and you've got a softer light, which is fantastic for gingiva. We can help you get these if you're interested in them. Contact us and Ivy maybe, and we can help distribute some of these for your practice. They're absolutely fantastic, and they're not very expensive to use. So you don't have to have a photography studio to take a good picture. But if you're going to be taking photos with this, you want to make sure that it's perfectly level to the patient and the plane of occlusion that you want it. You don't want to send your laboratory a picture from up here or down here. You know, this isn't the Instagram like best, you know, my nose looks best here. You want it to be straight on right there, all right, so that we can see all the details perpendicular to the plane of occlusion. You know, the most important rule in photography is having the camera and the patient level and straight, sitting upright with their shoulders straight, their head straight, so that you can see if they have a cant in their smile, you should be able to see it in the picture. Don't line up the camera to be even with the smile if the smile's wrong. We want to see it.
Make sure patient's face is nice and straight, shoulders is nice and straight and relaxed. Make sure they're not crooked or moved. You want to make sure this light in the circle and patient is nice and straight. The first picture I'm going to take just a full face shot. And I'm gonna rotate my.
All right. I have a lot of video on that, but maybe we should do a lecture on photography lab another day. Retraction there and smiles. These are his teeth at 4 months, which, by the way, for this case, for full disclosure and honesty, this was last week. Less than 2 months ago, I wanted to put on a couple lectures, and I wanted one of them to be an all-on-4 lecture. And we thought about one of our trickiest cases that we could present, and we saw John had surgery in January, and he would be ready just before this lecture. So I was putting this all together, trying to culminate this case just before today, and you'll see all this came out beautifully just this afternoon. So this was just last week in the photography studio. You want to look at getting this quality of picture, all right, for your laboratory. These are those teeth that we delivered at 2.5 weeks, okay? They're good. And I'd be proud of them. And in a lot of offices, that's what you're gonna see on Instagram as their finals. They weren't quite good enough for us. You have to ask yourself, how can we improve upon that? Because we could have just said, John said they're fine. He was ecstatic. They weren't quite perfect for us, right, Al? They weren't quite perfect. How can we improve upon that? We've got a chance to make them a little bit better. I'd like to see just a little bit more maxillary tooth in repose and a little less mandibular tooth, right? I think that takes a few years off the face. So we figure that if we change the plane of occlusion a little bit, we can bring those uppers down. We can intrude those lower anterior teeth just a little bit. Again, you ask John, do you have any changes? And he's like, no, I'm good. It's fine. You guys are great. Just do whatever you're going to do. I'll be happy with that. Perfect patient. We don't get those guys very often, right? It's a blessing when we do. So now we remove the provisional teeth, and we're going to take those teeth to the laboratory, and we're going to scan them over top of our new models that we're about to get so that we can make prescribed changes digitally. Teeth are off. I'm going to check all these MUAs for tightness. All right. This is a video showing how to tighten down those MUAs. We're torquing down multi-unit abutments. The straight has a different attachment. It looks like this, and we're going to fit it over top of there, and we just put it down 20 Newton centimeters. Important to do that on all the MUAs before the final impression. We already did the 5 angled ones here in the mandible. And then that is for the straight MUA. That has a different attachment than the angled MUA. The angled MUA looks very much like a driver. That's going to go parallel in the side of the MUA, parallel to the implant. Yep, there you go. Okay, I'm going to find the MUA and get in there and tighten that one down. Move up to the next one. Find the screw, tighten that down. Make sure they're tight. Find this screw. So I'm using a handpiece, electric handpiece that torques out at 20 Newton centimeters, but you can also use a manual driver, a manual wrench, if you will. The next step is we have a verification jig to place to take a soft tissue impression. Whenever you're using multiple implants in an arch, if you're not doing so digitally, and I'm presenting this because I presume nobody's doing any digital here. The analog method is to splint them together and make sure that we verify passive fit on all these implants. These jigs we've milled out in our lab, so it's all one piece. It's the perfect jig material because there's no contraction, no expansion of those jigs. And we place them on the implants and we verify them visually, tactily, and with radiographs. And then we use them to pick up a soft tissue impression. So here you see it on the model, and here you see them in the mouth, okay? And this is with our polyether adhesive attached to it, ready for a pickup. And here we are with the radiographs. We're looking to see that, okay, implant, MUA, and this is the coping for the jig right here. All right, we're looking to see that there is no gap at any of these interfaces. Okay, any of these. Because if there is, we have to section the we have to section the jig, we have to put it on there, take radiographs again, make sure they're seated, and then lute them together. That's very important because if you move forward with making a set of teeth, you can run into complications with your prosthesis if these are not perfectly accurate. And there they are on the bottom.
What do you lute them with?
So in this case, we've designed a verification jig digitally, all right? And this has been milled out of a puck, all right?
PMMA or what?
Right, it's like a PMMA. So it's milled out, and then we insert the copings inside there, we cement them inside.
If you section them, then put them back in, then what do you use?
So if you find that this is rocking and you cut it here in the middle, you can use any self-curing resins, all right, like Voco. For example, we use a lot of. If you had to section it and then take an impression, we would make a new verification jig to make sure that it was accurate.
So you don't use flowable though?
No, I don't use flowable. Yeah, usually these are self-curing resins set up in about 6 or 8 minutes. But if you have to section it, we want to come back and do another jig to make sure that it was accurate. All right, so that would be your preliminary soft tissue impression. We would pick up another one. Well, you wouldn't necessarily have to pick up, if the second jig was accurate, you wouldn't have to pick it up, right? But just something else to verify that it was perfect. So here we are, we have to take soft tissue impressions. There's the jig. I'll demonstrate briefly or show you how to take an impression under these.
Not a crown prep, but
What we're going to do, we're going to fill underneath the verification jig. Make sure we don't have any air bubbles, so let it go all the way through until you see it come through the lingual, and then step it back. You're giving the laboratory technician a perfect view of the intaglio surface of his future prosthesis. This verification jig was milled in-house, so we know that there will be no expansion or shrinkage of materials. And we get that all light body underneath. Get the heavy body corresponding to that material. This is polyether Impergum. We're going to put that over top of those pins and push it down and make sure that we can feel all 6 pins with our fingers. So we'll be able to retrieve it without having to cut the tray out. So there's all 6 pins in there. And we're going to do a little gentle border molding just like with the denture. And you ask John, stick out your tongue all the way. Stick it all the way out at me. And then go left and right with your tongue. Pull your tongue all the way back. Stick your tongue all the way out again. Pull it all the way back. Just relax your tongue while I work on your lips for a second. Right lip, left cheek, right cheek. Always go left cheek, left lip, right cheek, right lip. Stick your tongue out all the way at me. Pull it all the way back. Good. Showing our laboratory technician the extent of the peripheral
You get the idea of what we're having to do, just like a denture impression. You want to make sure that you have a good replication of the vestibule in the buccal and the facial, so that we know where that soft tissue lies. We can close all gaps in that area.
One more chance to try to put a little material into his beard.
And then you want to send it to the laboratory with your prescribed changes. There are very specific changes to make, such as color of the teeth and the midline and the occlusal plane and the things that you demonstrate on your FaceBo. And then there are generalized instructions. Don't get involved in the, move that tooth, this tooth that far, this tooth that far, this tooth that far. Again, like we talked about in the beginning, look at the overall picture. Look at the best teeth. Look at the side you like more, right or left. Appreciate it as a whole, and then try to make generalized changes from there. One rule we use with the patient's concerns, the 3 C's, the concern that they have, what caused it, and how we can correct it, right? So patient bites in their cheeks sometimes. We may have insufficient buccal overjet, or the prosthesis infringing on the buccal vestibule. Maybe they're too locked in there on the buccal. So you can notate how you think it might need to be corrected. That's a very good way to make sure that you address all the concerns of the patient. And then if they haven't already had the prosthesis scanned at our laboratory, you can send them over to scan it. We made changes on John. This was the final PMMA before zirconia finish we wanted to try in. So these were milled out, put in the mouth, and evaluated. And any adjustments that needed to be made were made on those. So this is John wearing that try-in set. He didn't wear these home, but looking at the changes and how they would portray into the final. All right, just a quick 3D printed material. And everything was deemed to be adequate. So we went ahead and moved forward with the zirconia, and we copied those PMMAs and designed them, and then it goes off to the processing of the zirconia. With the sintering here, we process those overnight typically. And then it's adding some stain is added. There's a lot of work that goes into that, and I don't mean to minimize the steps involved in that, Al. With your green state finishing, he puts a lot of time into carving those zirconia arches in the green state. That's that chalky state where you can mold it, and putting fine anatomy into it, and cutting back the gingiva to later stack that on, and then staining that before sintering so that you get nice translucent hues at the tips with your blues and your grays. There's a lot that goes into that, so I don't mean to minimize that. It's absolutely fantastic, the job that you do. And then you're gonna come through and add that porcelain and glaze those teeth, stacking the gingiva, almost ready for delivery. And here we are putting them in. It's very important that we torque these in. All right, once we deem them to be perfect and they're ready for delivery, I'm going to torque them into 15 Newton centimeters. Little quick demonstration of that on this video. Maybe not. Just a quick second to start it.
The MUA abutment screws, 15 Newton centimeters. And we do that on each one. I got it. One more.
This is, by the way, a great little torque wrench to have in your office because with a lot of the torque wrenches, they have that lever that you pull and you guesstimate how hard it's going in. This one, you can set it at a certain torque.
Perfect.
And then it'll break when you get there. Just click. And that's what you heard on there, just that click, right? It's this is the name of it. You can contact me later if you're interested in picking that up. So this was today. There was a lot of work this last week, but this was today. This is his final teeth, full contour zirconia with the gingival cutback, stacked gingiva, and this is a retracted intraoral view. And our photographer, Karina, does really great animated videos. And I'm just loving the detail of all these line angles and all these embrasures. Anyone else get a little motion sick right there? And then it's back to the photography lab to document what we've done, looking at a full range of lip postures all the way from closed through repose and into smiling. And I'm just loving the stain and the contour of these teeth and the translucency at the tips and into the final smile. And then letting John see them.
Done now.
Get it done right.
Very nice. Oh yeah, man. Look at me. Small. Yep.
Yeah, I guess he likes them. Now, John's a great guy, and he's an engineer and a builder, and he knows what goes into all this work. He's the most humble and kindest of all men who does tens of millions of dollar deals in construction. And I just think he's great. He's very appreciative of all the work that went into this and understood it all along the way. And one of the things, just to tell you, because this is about people really, John went 59 years with those teeth. And he said today, it took me 59 years to screw them up. It only took you 4 months to fix them, right? But the other thing that he said that almost, brought tears to our eyes today was he said, I wanted to fix my teeth my whole life. And my daughter was getting married, and I swore I was going to fix my teeth for her wedding, but I didn't have time to do it because I was busy working. And so I have all those pictures from the wedding with my old teeth. And then my son was getting married, and I was going to do it, but I was too busy working. Because he's a very successful guy, works really hard. And he said, and then my granddaughter was born, and I didn't ever want to have her see me smile like that and scare her. And just about brings tears to your eyes. And going back to why people do this and cost, don't ever presume that it's not important to them or that they don't need to have it done. Because he'll tell you it just completely changed his life in the way he sees himself and the way his granddaughter now looks at him. It's just a special moment, and that's why we do what we do. And these are his finals there in the photo lab. And from start to finish since January the 16th, I believe, here to May the 19th. We're all over social media, so find us and like us and tell your friends about us. I told you about those dates coming up next year, so contact us if you're interested in coming to that series of events next year.